derde. Did you do derde? No, they're both E's. De, e, r, de, e.
Sophie, you're not on mute.
Oh, sorry.
Okay, thanks everyone for joining. Good afternoon, good evening. Okay, I guess we are ready to start. Good afternoon, everyone. My name is Jawdat Sanuri. I'm the product manager for cardiac ultrasound from GE Healthcare. Thanks again. Welcome to this ACE course, the advanced courses in echo from GE Healthcare. Today's session is an in-depth session for strain echocardiography, where we will talk about the origins of strain, a little bit about the technology background, and whether it's tissue Doppler or speckle tracking, and then we'll talk about the various strain applications that are out there, and implementing or integrating the strain echocardiography into the routine echo practice. So without further ado, again, this is some of the things, again, that we'll be talking about. We'll discuss tissue Doppler, starting with the normal PW, TVI, what these mean, the difference in namings. We'll talk about the parametric imaging, how we can do it. We'll talk about event timing, the benefit of event timing. Then we'll talk about the various modes of utilizing tissue Doppler, tissue synchronization imaging, tissue tracking, strain rate imaging, and strain imaging. Then we'll talk about speckle tracking, 2D strain, all the different 2D strain that we can do. And then, of course, the cream of all the speckle tracking and 2D strain, the automated function imaging, which gives us the ultimate result, which is the global longitudinal system of GLS, global longitudinal strain. We'll also talk about a little bit about auto-AF, as well as 4D strain and the latest in strain when it comes to RV strain, as well as left atrial strain. So please, again, as always, this is an interactive session. Please do stop me anytime to ask any questions. This is, again, our GE version of the know-how, how to implement strain and utilize it, and how to do it on our GE equipment mainly, and how to implement it into your routine echo. So keep in mind that your mics are on mute, and please keep them on mute to avoid any privacy issues and noise, background noise as well, that may intervene. But if you have any question, you can just unmute your mic anytime, and please feel free to stop me anytime. Okay, so the first thing we'll talk about when it comes to tissue Doppler, the first application of tissue Doppler was PW, pulse wave tissue Doppler, which was mainly utilized in order to assess the diastolic dysfunction. As we know, because unlike the mitral flow, the E and A ratio, EA ratio of mitral flow, the E prime A prime ratio is not compromised or influenced by LA pressure, as in the case of mitral flow. Mitral flow, as you know, as pressure builds up in the later stages or higher stages of diastolic dysfunction, you know, LA pressure builds up, and so it preserves or reverts back the EA ratio. As you know, the EA ratio typical is 1 to 1.5. Then it becomes less than 1 in grade 1 of diastolic dysfunction. Grade 2 onwards, because of the LA pressure buildup, it gets reinverted again, and then it shows pseudo-normal EA ratio, even with grade 4 or grade 5 diastolic dysfunction, while tissue Doppler E prime divided by A prime gets inverted, of course, with the first grade 1 of diastolic dysfunction. However, it remains less than 1 throughout the ratio. And of course, the ultimate measurement that we do is E over E prime ratio, and the cutoff, I think, of 8 or 10, indicating presence of diastolic dysfunction when you divide E over E prime as an indication of diastolic dysfunction. Then tissue velocity imaging, which shows us the actual velocity in color Doppler for the entire field of view or the window that we select, showing us, of course, TVI shows us the instantaneous velocity. So eyeballing alone for this kind of image is not really informative enough. Of course, we need to do the parametric imaging and the diagnosis, or selecting different modes, as we'll show you in the later views. However, the tissue Doppler in general is angle dependent, as we know, so it shows the velocities along the beam, either towards or away from the probe. And of course, this is why in TVI is almost predominantly used only for apical views, because it shows us the longitudinal velocities along the apex. And of course, since 70% of the myocardial fiber is actually longitudinal, it worked well in that aspect. However, in short axis, for example, if you try to use tissue Doppler in short axis at these lateral sides, then you are assessing circumferential velocities, and that would influence circumferential strain. While on the top segments and the posterior segment here, it will actually be detecting velocities that are in the radial direction, hence assessing strain in the radial direction. This is why it was almost rarely ever used tissue Doppler in short axis views. You rarely ever see it. So the tissue Doppler profile is simply pre-systolic motion, systolic motion, and E prime. And of course, the mean velocity of a pulse wave tissue Doppler is what is represented in color coding, instantaneous color coding of that velocity in the TVI. That's basically what TVI means. And of course, just like pulse wave tissue Doppler, which has very, very, very high sample rate, color tissue Doppler requires high sample rate, because if you have a high sample rate, you can distinguish between pre-systolic, systolic motion versus, for example, normal low frame rate of tissue Doppler, where the mean information that you can extract from it will not be sufficient and good. So this is why we always say in TVI, we need to require the highest frame rate possible. What can we do with it afterwards? We can do either anatomical M mode or what we call curved anatomical M mode. Here, this is an example of anatomical M mode. So you can see number 1 is basically this apical septal segment. Number 2 and 3 is the mid segment. Number 4 is the basal segment. And you can see the actual grayscale in the background, in addition to the actual red and blue. Brighter red means higher velocities, brighter blue or lighter blue means also higher velocities between systole and diastole. And you can see, of course, the basal segments always have the highest velocities because they do the most excursion or displacement towards the apex. Then we can also create a curved anatomical M mode by creating simple points across the entire LV, as in this example from this 4-chamber view. And here again, you can see where 1 is, which is this one, now this area here, 2, 3, 4 up to the apex, and then 5, 6, 7 is also stretched all the way. So you can see from basal, mid, apical, septal, and this is the apex, and then apical, mid, basal, lateral wall. And again, the velocities you can see red and red towards the apex. And of course, the apex itself, the tissue Doppler means nothing in the apex. So this is why we look only basal to mid to beginning of apical segments. Likewise for lateral, but we never look at the apical information in tissue Doppler at all. Okay, so how is this helpful? We can see the instantaneous displacement, for example, during systole, these segments, which are actually the inverted base mid apical segments, of this, I think, inferior wall, maybe if this is a 2-chamber. But you can see these segments are actually moving away from the probe down during systole. However, this frame is actually during diastole. So the frame itself on the left is actually, in this time, it is here in diastole. However, but during systole, you can see the same segment 3 to 4 is actually moving down. During systole, it means it is actually dyskinetic. It is actually stretching, compensating for the contraction that is happening between 1 and 3, which is normal healthy tissue. 3 to 4 is actually an infarcted area that is actually not contracting properly. So the TVI profile, again, we have the systolic, we have the first of all, you have the IVC, you have the systole, you have the IVR, and then the E prime wave, and then mid diastole and the A prime as well in tissue Doppler. And of course, this is also related and can be assessed in addition with event timing, where we can have the mitral valve closure moment, the aortic valve opening before systole, and then aortic valve closure, which indicates end systole, and then mitral valve opening again, which indicates the beginning of diastole. So we have the time of the aortic valve opening, we have the time of mitral valve opening within each ECG cycle. And as you can see here in this example, from this TVI and from the Doppler, we simply use the normal event timing. So you go to the spectral Doppler of the mitral valve and of the aortic valve, and you can see here, this is the mitral valve opening and closure. Once you select those, then they are indicated here in the signal itself, or in the parametric trace itself, and then likewise for the aortic valve opening and closing. So every time we place a region of interest, or an ROI, what we call it, or a parametric sample, then you can see systolic motion, E prime and A prime, and you can see the timing and difference between pre-systolic motion, systolic motion, and of course this is the time of the IVR period, and then you have the mitral valve opening again, and so forth. So you can assess different parametric ROIs for different zone, basal, mid, apical, and of course, as always, the basal usually have the highest velocities. So if you place more than one region of interest, you will see the basal waveform attains the highest velocity during systole, as well during diastole. And the closer you are to the apex, the lower the velocities. And you can see the apical region of interest, where you have the lowest peak velocity in systole, and also the lowest peak velocity in diastole. However, all the traces, as you can see, have the same layout: systolic motion, E prime and A prime motion. The velocities towards the apex during systole, because the apex is here, so it is positive. In other words, velocity, meaning towards the apex, towards the probe. Red here indicates positive velocity, or towards the probe, and blue indicates negative velocities, which are here. If you go to this is systolic frame. If you go to a diastolic frame, you will see the entire thing is looking blue, because all the myocardium will be moving down with negative velocity. So in addition to parametric imaging, also we can rely on the time to peak velocity, not only the actual velocities, but the time, the onset of the QRS, as you can see here, to the peak velocity for each region. This time is in milliseconds, can be translated in the same color Doppler window with a different color map that indicates the time to peak velocity. So it can show me the time to peak velocity here. The green, or the greenest color, is 0.06, which means 60 milliseconds after QRS. The reddest color is 500 milliseconds or 510 milliseconds after the QRS. So this indicates all these segments reaching peak velocity, or peak systolic velocity, within the green zone, which is around 100 to 200 milliseconds, or 200 milliseconds more or less. However, if there is an area of delay, you can see that from this 4-chamber as well as this 2-chamber. And the example on the, and that's of course is a synchronized patient, normal synchrony. And here on the right, you can see these septal wall and also the inferior wall from two chamber these are the areas of delay. You can see that the red color indicates they reach peak velocities close to 450 or 500 milliseconds, which is a huge delay from this normal green, which is 200, or even this yellow, which is 250, 300 milliseconds. And that indicates a huge difference in time to peak velocity. It's a sign of asynchrony. So if the velocity curves have different time velocities, you will find different phases for them. So if you have these typical normal peak velocities with a huge difference in phase, and also strain, of course, with normal strain but huge difference in phase, that's usually a suggestion that this could be a good candidate for pacemaker, of course. So this is again an example of an live image of tissue synchronization imaging for a normal patient. And this is a synchronous patient, and this is actually the same patient immediately post implant of pacemaker implant. You can even see the leads across here. Not sure if this is the same patient, but anyway, showing this is post-implant. So you can see here now the timing is more uniform compared to the one on the left here, where the timing is still with a huge difference in time. Additional information we can also get from TVI if we do the what we call the time derivative. We can actually get the displacement or the area under the curve of this time integral, sorry, the area under the curve, which is actually the displacement. And that gives us information similar to if we are doing, for example, M mode on the annulus. The only difference, tissue tracking can give us information about displacement everywhere in the myocardium in each region. And that's how it looks like, because each curve, each velocity curve is different. Again, the apical ones have lesser peak velocity than the basal ones. Hence, if you measure the area under the curve, the basal one will give you a different displacement, high displacement, 12 millimeters, the normal for a normal adult. For the annulus and each part of the myocardium. Here, this is an example of real-time tissue tracking using tissue Doppler to detect and give a color coding of the displacements. It means this part has moved towards the apex. During systole, as you can see, it's only measured during systole. If you freeze this beyond systole, nothing will change from there after in systole. It only shows the displacement during systole. And here it's showing this part has moved 0 to 2 millimeters, yellow 4 millimeters, orange 6, 8, 10, 12, and above 12 millimeters for the base. And you can see, even judging from this gradual change in color, that there is healthy longitudinal contractility throughout this LV from lateral wall as well as septum. Here, this is an example on the bottom left, where you have a myocardial infarction in these segments. You can see on the this is, I think, a two chamber in the inferior wall. You can see the change in color: red, orange, yellow, green, blue. It looks almost normal, but here in the anterior, you can see definitely something really wrong in the apical and mid, and maybe only the basal looks right. And you can see it's even compensated because it changes color: red, yellow, orange, yellow, green in a short distance, because it's compensating for the lack of contractility. Here, this whole segment only contracts by 2 millimeters as a result of this information of tissue tracking. There's also another example of dilated cardiomyopathy. The entire myocardium is not contracting well. So this is a good indication about systolic functionality from tissue tracking, and also not only regional, but also segmental. You can see segmental abnormalities. Again, the reason there is no color here is because this tissue is actually pulled down. So it's a negative displacement, in other words, during systole. This is why it doesn't give any color. It just gives gray, because displacement color coding is only towards the apex, not away from the apex during systole. Okay, in addition, we can also get strain rate imaging as well as strain imaging, and we'll talk a little bit about what we can do with it. Again, mainly with the curves and with the color with the curved anatomical M mode and the traces, but we'll talk about that in a second when we discuss the 2D strain as well, because that's also additional information. So again, that's how strain and strain rate is calculated. The differences in velocities, because we have the velocity here, we have the velocity here. So the differences in these velocities can give us an idea about strain and strain information. So for example, here, this is a segment that starts with 1 centimeter length, and then it lengthens by 0.3 centimeter. That means it has a positive strain of 30%. If the same segment starts with 1 centimeter and then it shortens by 0.3 centimeters, so it means it has a negative strain of minus 30%, because it's not stretching. It's the opposite of strain or stretching. It is actually compressing longitudinally. Likewise for strain rate. So for example, if you have this segment starts at 1 centimeter, ends at 0.7 centimeters, again, it's shortening. It has a negative strain of 30%. But here we have two examples. On the blue one here, the segment shortens that 30% over the span of 2 seconds. As you can see, it did it slowly. The red one here shortens over the span of 1 second. It's much faster. So the strain rate on the blue one was minus 15 per second. The strain rate on the red one was minus 30 per second, despite at the end of the day, they had the same strain. So again, this is additional information for strain rate if you like to do these advanced things about strain rate as well. However, tissue Doppler, again, as I mentioned earlier, the first thing, it has a pitfall, which is the angle dependency. So on the same image here, if you are looking at the velocities and the strain and any value between the line here and the line here and the line here, you have different angulation. So for example, in the line here, in this apical segment, you are actually not only picking up longitudinal strain because the apical contractility is in this direction longitudinally, but also you're picking up radial velocities, which means you are mixing the two. And of course, radial velocity and radial strain, or radial strain predominantly, has actually an opposite value, because longitudinal strain during systole is actually negative. Radial strain during systole is actually positive. So they can intervene with one another. This is why we always try to make it as longitudinal as possible. Sometimes they do only one wall at a time to try to make it as longitudinal as possible when it comes to tissue Doppler strain. That's where the need and the evolution of speckle tracking based quote unquote 2D strain came in. So 2D strain is actually based on speckle tracking. What is speckle in the first place? Speckle, as you can see here, basically in the image on the left here, you can see speckle is basically a group of pixels that have a specific shape that can be recognized by the algorithm. From one frame to another, the algorithm looks for that speckle. It finds that it moved again, moved again. That means each time between one frame and another, I can tell the velocity because I know the distance. So in other words, distance divided by time equals velocity. So I know the velocity, but unlike tissue Doppler, which could only detect velocities going towards the probe or away from the probe, we can actually detect the entire velocity. We can even separate between the component, the longitudinal component and the radial component, because each one with the mathematical equations can be separated and can be calculated, and we still know the angle of the motion. As a result, we can separate these velocities. This is why for the first time ever, we can actually do with 2D strain, we can actually do circumferential strain, for example, or even radial strain. We can do strain from short axis views, period, regardless if it's circumferential or radial. However, for speckle tracking to work, again, always you have to keep this in mind, because the algorithm needs to recognize the speckle once, and it needs to calculate the velocity. So two conditions have to be met. One, the frame rate has to be high enough that I don't start with this speckle and then end up with this speckle, because this speckle might be a little bit different than this one. This one a little different, I can recognize it and track it. This one also different, I can recognize it and track it. But between the first speckle and the one in the number 5, the shape of the speckle has changed so much that the algorithm does not recognize it anymore. So this is why you need high frame rate. And of course, the typical rule of math or physics is that you need to have more sample rate to have more accurate data. The other issue is that if I have very, very extremely high frame rate, we can have in 2D 200 frames per second. Speckle tracking will not work, simply because if I have very high frame rate, that means between 1 and 2, I will have 10 different images as well. And if the speckle has moved so little, the machine cannot measure the actual distance that it has moved, because the distance is very little, so it cannot calculate it accurately. So this is why we always say for speckle tracking, 2D strain, for AFI, always try to stick between 50 and 70 frames per second. Higher frame rate is also required for higher heart rate. So if your patient is tachycardiac, you have 100 beats per minute, then maybe you need to stick with 80 or 90 frames per second as well. But the rule of thumb always is if you have 60, 70 frames per second, it will work no matter what your patient's heart rate is. So again, as a result of speckle tracking 2D strain, we can analyze longitudinal strain as well as transverse strain from apical views, and from short axis views, we can analyze circumferential strain as well as radial strain. And here you can see examples from a 4-chamber view. So here on the segmentation is done from apical as well as short axis views. So we can analyze longitudinal velocity. We can get actually values for longitudinal velocities, longitudinal displacement like tissue tracking from this 4-chamber view or apical view, regardless what it is. We can also detect longitudinal strain rate, and here you can see the strain curves longitudinally, which is the typical strain curve, negative strain up to the peak at end systole, and then diastole defaulting almost near 5%, and then diastasis, and then again defaulting to 0 after atrial contraction. So
excuse me, can this
yes?
be used in stress echo? I mean, to compare the GLS at rest and at peak of stress echo? Is this valid?
Thank you, very good question. Absolutely, yes, it is, and it's used, and we have an application for it actually. It's called AFI stress, and it's coming in the next slides. So yes, very, very good point. Of course, yes, it can be used. Okay, so yes, so you can see from the strain curves the peak velocities for each segment, as well as the peak strain, the peak strain percentage for each segment, as well as the timing of the peak strain. So that also can give you an indication of asynchrony if there is any from these curves, just from this 4-chamber. And you can see the strain curved anatomical M-mode starting from the yellow here all the way around to the light green or light blue here, and that's from the basal, here's my cursor, from the basal septal mid apical to the all the way to the basal lateral wall. Now strain is different than strain rate, because strain gives you the instantaneous strain up to the maximum, and then back to again to diastole. However, strain rate here shows me the instantaneous change in the strain, which is basically strain rate, and then of course the peak of the curves for the strain rate should be in the mid systole, not at end systole. At end systole, the rate of strain change drops to 0. There's no more change, and then actually it is positive during diastole, during E prime, and then again positive during atrial contraction. So usually they use this curved anatomical M mode to detect if there is any post-systolic shortening. If you see this red, any of this red in any segments beyond end systole, beyond aortic valve closure, then that means it's a post-systolic shortening. or if it is an entire region, then it could be asynchrony. Depends also on the values of the strain itself, because usually if it's a post-systolic shortening, you'll have a lesser slope here, and then it keeps going on until beyond systole. But if it is simple asynchrony, you will have more or less the same waveform, but with a time shift altogether. The onset of it and the end of it will be changing. So that's another way to look at it. And then you can also have a look at transverse strain in short in the apical views, as well as transverse displacement. So it's displacement of each of these segments towards the center line. Okay? And again, that's additional information that can be procured from this speckle tracking. For short axis views, as you can see here, we can detect the radial strain, which is actually a positive strain during systole, or the circumferential strain, which is a negative strain, similar to the longitudinal strain curve. You have the negative strain up to minus 20%, and then defaulting again to 0 between diastole and atrial contraction. We can also get radial strain rate, radial displacement, as well as circumferential strain rate, circumferential displacement, circumferential rotation as well. The parameters are really many. You can get endless information. There's also the twist or torsion, the difference in rotation between the apical base and the apical ring and the basal ring, and the torsion or the twists in degrees between the two rings, the difference in rotation between the two. Then that brings us actually to the if I may say, the holy grail of all speckle tracking, all strain parameters, which is the GLS, the global longitudinal strain, which has been globally, clinically validated and accepted as the new quote unquote EF. As an indication and as an indicator of cardiac LV function. And of course, this is just from taking the 3 apical views, the 3-chamber, 2-chamber, and 4-chamber, having the region of interest for all 3, and then the longitudinal strain for each of the 6 segments in each of the 3 views. Once you have the long axis, the 2-chamber and the 4-chamber, then you have a collection of all the data. Again, you can see the segmentation here. This is an example of during the process of doing AFI, automated functional imaging. Here we have a 4-chamber view. So the region of interest is drawn, the segmentation is done, the peak systolic value for the strain curve of each one of them is given. Peak systolic, meaning this is why you can see the aortic valve closure. It means anything that is beyond the aortic valve closure is not considered as part of the peak systolic, because we are assessing the global longitudinal strain, of course, systolic strain. And if there is any segment that is not detected well, it will be given with an X, as you can see here, meaning that the algorithm thinks that this segment is not traced well for the cardiac cycle. And this is a static image. This is only showing the strain values. However, here we will see the actual region of interest tracking the actual apical lateral segment, as in this 4-chamber. So we can check visually check the strain, the region of interest, and the speckle tracking. Is it tracking the segment well? If I see it's well, then I can overrule and I can accept, or I can actually omit any of the segments that I don't see fit. However, if we omit more than, I think, 3 to 5 segments, then the GLS is not calculated. The GLS for all the segments will not be calculated if I have too many segments. So again, from 4-chamber, from 2-chamber, from 3-chamber, again, you can see the strain curves for all these segments. And again, unlike velocity, strain apical segments should have the same value as the basal segments, because tissue Doppler again is angle dependent. Apex is meaningless, but here we have the actual apex in 2D, so we can do speckle tracking. However, it is very critical that we have the right apex. It's an open apex. if you are playing this 4-chamber and you see huge excursion, for example, of the apex, that means you are foreshortened. Typical acquisition skills are needed. Maximum opening of the mitral and the tricuspid for the 4-chamber. The LVOT should be closed. The apex should be maximized with no major excursion. Likewise in 2-chamber, likewise in 3-chamber, mitral valve is open, aortic valve is open, and again, no major excursion of the apex, meaning that there is no foreshortening between systole and diastole. So once this is acquired, then usually you will get optimal results for the strain AFI values. You will get again the 18 segments in a bullseye. As you can see here, these 18 segments are projected on the bullseye. The basal ring is the outer, mid ring, apical ring, and of course, as per the standard coronary distribution of segments, we can generally say this is LAD territory, circumflex territory, RPD, or right coronary artery territory. So when you are looking at the bullseye of strain values, this is the typical bullseye. This was the old 18 segments. Now it's modified 17 segments. This is a normal AFI, and this is an AFI of a patient with an LAD infarct. There's also a new color coding of the strain values instead of this, because here the strain value is showing me red and blue. Red, of course, is negative strain. Blue is positive strain. During systole, longitudinally, all the segments will have basically red color because they are simply contracting, they are simply shortening. However, if there are segments with positive strain, that means these segments are actually stretching, which are the anterior basal and the mid from the 2-chamber, which is here. So these two segments, as you can see during systole, are actually stretching, and that's why they are getting positive values, and as well as the anterior septal here, they are getting positive values. You can see the blue here, you can see the blue here during systole. That indicates they are actually dyskinetic. They are not hypo or akinetic. They're actually dyskinetic in that aspect. Here, however, this is not concerned with this color code is not concerned with dyskinetic motion. It is concerned with simply normal in green, which is anything above 12%. Borderline hypokinesia in yellow between 12 and 8. Anything less than 8 is considered akinetic and or hypokinetic, and it is simply given in red. So even if it's plus, it's still given in red because it's still abnormal contractility. Then there is also with AFI as well, you can do a different color coding, which is the time to peak strain. And that is again, this curves here of the strain. So each one of these, So each one of these curves, this time from QRS until this peak strain is represented in milliseconds. Here you can see they're all in sync, so there's not much time difference. Even if it's 50 or 100 milliseconds, you will still have the same color for the peak strain dispersion. However, if there's a huge difference in time, then as you can see here, from 288 or 300 milliseconds to 500 milliseconds, that is more than 200 milliseconds difference, and that's definitely going to show me completely different colors, indicating there is an asynchrony here between the anterior lateral walls and the posterior inferior walls as well. Then there's also myocardial work, two parameters or two main information. It actually calculates the actual work, which is the multiplication of strain with blood pressure. So if the patient's blood pressure and the strain goes down, the end result will remain the same. So relying on strain only can give us false perception of deterioration or improving for following up with a patient whose blood pressure fluctuates or changes between one study and another. So here myocardial work can give us a better indication about the actual work and the work index. In addition, it gives us also the average or the global constructed versus wasted work, and we can also compare it for each segment, how much constructed versus wasted work for each segment as well. So AFI for stress, as per your question, doctor, AFI can be used for stress. So here you can compare between different peak systolic strain from different studies, from different patients. So you can see, but also you can compare between different stages of the same patient. So you can have a bullseye for baseline, bullseye for low dose, bullseye for peak, and I will show you that during the hands-on session, which we will be doing on EchoPack in a few seconds or a few minutes. Then in addition, we can also do speckle tracking for or strain for RV or AFI for right ventricle, again using the typical 4-chamber view or an enhanced 4-chamber view for the RV. Typical RV 4-chamber view using speckle tracking will give us the 6 segments of the RV, 3 septal segments and 3 free wall segments. It will give us the average of these 6 segments, which is the global strain for the RV. It will also give us the free wall segments, or the average of these 3 free wall segments should be higher. And in addition, it gives also the TAPSE, the displacement of the annulus, since the whole thing is tracked anyhow throughout the curve. So you have the curves, you have also the curved anatomical M-mode in time for the longitudinal strain for the right ventricle as well. And again, it's longitudinal strain from the 4-chamber view for the RV. So RV can no longer be called, quote unquote, the forgotten ventricle, because it's we have one more probably much more easier and solid information to rely on assessing RV function. And of course, this has been standardized by the EACVI, and we in AFI RV follows these standards. So it has to be focused apical view, ROI, to include RV as well as septum. And of course, again, all these are being taken into consideration. Likewise for the left atrium, and we have AFI for LA. Again, for LA, we can take 2 views. We can take the 4-chamber and the 2-chamber. Again, for LA, we have to make sure that we have the maximum LA length. So even if the apex of the LV is foreshortened, of course, that's okay, because we are trying to take the real left atrium and the LA strain, and it calculates, of course, from 4-chamber and 2-chamber reservoir strain, conduit strain, and contraction strain. And of course, the reservoir strain equals usually the sum of the 2 other strains, which are conduit and contraction. The reservoir is a positive strain, conduit is negative, contraction is negative. So here, again, reservoir strain is for example, from 2-chamber, 35%, conduit -12, contraction -13. Here from 4-chamber, reservoir strain is -53, conduit -40, contraction -30. So again, if the sum of these 2 is equals to 53, the sum of these 2 is equal to 35, which is typical. And here's the biplane average as well. Okay, likewise, actually, during the process of AFI for LV, we can even, with one button, I will show you that in the real practice, we can just also detect the endocardial tracing that will enable us to measure the volume of the LV in 4-chamber as well as 2-chamber, and giving us the Simpson biplane ejection fraction. We can do it with an O2EF measurement separately, or along with the AFI, along with the strain, and that's a possibility simply because we are still using speckle tracking. We are detecting the endocardium. If you remember, with the region of interest for the strain not only includes the endocardium, but epicardium and the entire myocardium. But we use this endocardial border to detect the volume of the LV, diastole, systole from 4-chamber, 2-chamber, and Simpson biplane, of course, automatically. Then there is 4D strain, and 4D, unlike 2D, we don't have a cross section of the image or of any of the segments. We have the actual entire segment within our pyramid, within our field of view, as we discussed last time. And of course, all the speckle within the myocardium, the endocardium, and the epicardium of this segment, of this building block, of this igloo, and then, or the LV, and then we can make overall assessment for this strain, for the radial strain, longitudinal strain, as well as circumferential strain for that segment. We have also, with G, we have one more information, which is called area strain, which is basically a combination or summation of both longitudinal and circumferential strain. And you can see that when you are trying to do the 4D strain, if you ever try it, there's a button called area strain, which gives you actually the area of the segment strain. So here, longitudinal, hopefully these loops will play. So here you have the instantaneous longitudinal strain, and you can see the curves. Circumferential strain, again, circumferential strain curves look similar to the longitudinal strain. And of course, area strain curves also look similar, but with higher value, because as I mentioned, it's basically the sum of these two strains, longitudinal and circumferential. And then you have radial strain, which is the inverted strain, which is where the thickness increases during systole of each of the segment. This is the average thickness of the segment. And of course, because the original length of the thickness, or the original thickness during diastole at end diastole is very low, you will see the actual value of the radial strain is very high. You can see values as high as 50 or 70% for radial strain, which is also normal for a normal patient. So just summary, we spoke about, again, tissue Doppler, tissue velocity imaging, tissue tracking, TSI, strain rate imaging. We spoke about 2D strain, what we can do, longitudinal, circumferential, radial and torsion. And this strain actually, 2D strain is actually, for us in GE, we strategically made it available only in the EchoPack, because these are in-depth strain that you might want to do, and you will not do it standing up next to the machine or while the patient is waiting. You will do it for in-depth analysis if you want. So that's why we have it available on the EchoPack only. However, AFI, which is routinely integrated into the echo examination, is available on the echo machine. It's available on almost every echo machine that we have from GE, as well as the EchoPack. And of course, it can also give peak strain dispersion, myocardial work, and AFI with stress, where you can have a bullseye for each stage. If you're doing exercise, you'll have two bullseye next to each other. If you are doing the vitamin 4-stage stress echo, you can have 4 bullseye: baseline, low dose, peak, and recovery. You don't even have to do wall scoring anymore, as you mentioned. Then you have OTF, and of course, for the strain. In addition, of course, we all speak about AI. Again, you have the AI integration in all these, even including strain parameters. Again, AI for the routine 2D measurements, as in this example, where we use AI to measure the Tychel's ejection fraction using parasternal long axis view only. Just by pressing the auto button, the machine will do all these measurements and in diastole, in systole, automatically in a fraction of a second. 99% accurate, 100% reproducible. It saves 80% of the clicks required to make this measurement. It saves actually 85% of the time it takes to make such a measurement. Likewise, for AI spectrum recognition with cardiac auto Doppler, we've had cardiac auto Doppler for like 3 years now, but now there's even automatic spectrum recognition. The machine automatically knows what you are trying to measure, as in this example, from this view, 5-chamber, PW cursor at LVOT, the baseline is elevated. So the moment you click measure, the machine knows what you're trying to measure and selects it and measures the LVOT tracing 5 times, giving me the average of the 5 measurements, VTI, LVOT maximum, mean, maximum and mean gradient, VTI, and the time of the ejection time. 98% accurate, 100% reproducible, 3 times less interoperator variability, 93% reduction in the time it takes to make such measurements in Doppler. So imagine each Doppler measurement, you'll have a 93% reduction in time. Again, AI is really, and of course, the same thing for strain. If you're doing AFI, AI will also select the views, do the region of interest also automatically without need to do anything manually, as you will see in the real-time examples when we go to the hands-on. Before going to the hands-on, are there any questions or comments? Okay, so let's start. I think I have some images here. Yeah. So here we have we don't have the actual mitral flow. Maybe we can go to the archive. We'll start with the diastolic dysfunction. So if there are any questions or comments, please feel free to ask anytime. Let me just hide this again. You can also write questions or comments in this chat box where it says chat, or you can raise your hand and say something if you want to. So anyway, let me just go jump to the study that I'm trying to capture here for the mitral flow as well as E prime, basically. Okay, at least here we have a mitral flow Doppler. So again, the first use, as we mentioned, for tissue Doppler, first of all, you have the normal flow for mitral. And here, when we go to measure, you can see that AI went to work immediately. It knew that I'm trying to measure that I'm doing the mitral valve, that I'm doing EA velocity, and it's done it automatically. So if I just exit the measurements, yeah, and just press measure, you can see how AI goes to work directly, and it knows the measurements from the image and from the Doppler, and it's done the E slope, and the A and the EA ratio. You can see here E velocity, deceleration time, deceleration slope, A velocity, and the EA ratio. 1, 2, 3, 4, all 4 complete cycles that are available. If there's anyone that I don't believe in or that I think is wrong, I can go here, for example, to this one and say exclude this one, so it's not in the analysis. I can also increase or reduce sensitivity if I believe the peaks should be higher or the sensitivity should be more. And when I'm happy, I can either approve or store the image. If I store, it will store the image with the measurements, showing it to whoever reads the exam later, or I can just approve the measurement without storing. The nice thing is that once I approve the measurement, and now I've done the E, and you can see here it calculates E over E prime automatically, not because it knows, but because it was done before. Here with the tissue Doppler, I have the cursor, the pulse wave cursor of the tissue Doppler at the annulus septal annulus you can see here, and here's my E prime and A prime, and of course systolic velocity. Again, if I go to measure, the AI will go to work, and it knows I'm trying to measure E prime, and it measures it 1, 2, 3, 4. And 4 is not because it only measures 4, but because I have 4 complete ECG cycles, and when I approve this, then automatically it calculates E over E prime. Again, if it is above 10, I think, then it's a sign of diastolic dysfunction for that patient. What about normal tissue Doppler? I don't see I have any here in this exam. So I'll go back again to patient. Let me find actual tissue Doppler and see how we can do the parametric imaging, the strain imaging as well. So this is a normal patient. All right, so here we have a tissue Doppler image. As you can see, again, it's an apical view. Okay, so we can do the Q analysis here, and we can put parametric region of interest, and you can see each place I place a marker, I get a trace for it. So here's again systolic velocity, E prime and A prime for each one of these lines. And you can see here, this is basal. The yellow one, for example, is simply basal septal. The green one, the red one is mid septal. The light blue, yes, if I may, or light green is the basal lateral. The grass green is the mid lateral. So here's systolic motion, E prime and A prime. You can see they're all phased together. So the time to peak velocity from here to the peak is almost identical for all. And you can see now, if I place apical segments, you can see the peak velocities are much less for the apical segments, simply because the apex does not move as much as the rest of the myocardium. So the apical, the pink one is less than the green ones. The orange one is less than the red ones, the peak velocities wise, systolic as well as diastolic. So this is one information that we can get, which is the parametric imaging. Again, we can also do tissue tracking, which shows me a color coding of the time to peak velocity. However, I think the timing here is not proper for some reason. So this is systolic, and the QRS here, the onset of the QRS is not proper. There's something wrong with this data set. Here we'll see it with tissue tracking. Oh, there's an abnormality. You can see the entire the whole thing is moving 0 to 2 millimeters. There is global hypokinesia here, actually. Okay. Then we can go to strain and strain value, strain and strain rate imaging. So here's strain imaging, and here's strain rate imaging. Again, strain and strain rate imaging, looking at the image here, has no value or indication whatsoever. It is the curved anatomical M mode that will help me, and that is when I go to Q analysis, I can go to curved anatomical M mode, and then I can go to the region of interest. I can create a region of interest starting from here, going all the way around. And then, of course, I can increase the gain. And then I have the strain rate value, as well as the strain imaging value, as well as the tissue tracking, showing the different tracking, as well as here's without. curved anatomical mode. So you can see the tissue tracking with the color coding. Sorry, the data was corrupted without the Q analysis. Okay. This raw data seems corrupted somehow. Anyway, so here we'll go to the next patient, which is and I will show you the same things with triplane tissue velocity imaging. And we'll be able to see the TSI for triplane as well. Let's just allow time for the EchoPack to go back to the raw data. Please allow me to close the PowerPoint because it's intervening with my graphic card on my EchoPack. It's slowing my EchoPack. It's also with the Zoom calls, it slows the graphic cards a little bit. Okay, it's this one here. Okay, so you see here we have a triplane acquisition with tissue velocity imaging. So we can do tissue tracking, and here it gives us an indication about the displacement during systole. Okay, and we can see the tissue tracking, we can see the TSI. So TSI shows me in color coding if there is delay, and you can see, of course, as always, tissue Doppler in the apex means nothing. It is these walls here that we are looking at, the septum and the lateral wall, the posterior and the anterior septal, the inferior and the anterior here in the two chamber. You can see there is no difference in time from aortic valve closure, aortic valve opening to aortic valve closure. It is all green, which means this time will be, if we change the time of the TSI, it will give us also the time in milliseconds, but nevertheless the color coding is same, so there is no asynchrony in here. However, we can also do Q analysis. We can look at the parametric imaging, the velocities at each position, and we can also do the strain rate imaging, for example, and the strain imaging, and we can do the actual strain rate values for each area and the strain value for each segment. So here, for example, this segment, here's the strain curve, and you can see the peak systolic strain is 20. And you can see the green line showing the angle of the beam, because whatever the origin of the beam of the signal is, that's where the angle. And you can see the more lateral you are, the more off axis you are angle-wise, even here. So this is again the pitfall of tissue velocity strain. Then we can go to the actual strain from 2D, from speckle tracking. Instead of Q analysis, we can just go to automated function imaging. This triplane is only at 37. frames per second, hence it cannot be utilized because the frame rate is very low. However, this tri-plane here is actually at 50 frames per second, so we can do AFI here. But before that, let's do the one that I pre-selected, which is, I think, in a different study. Let's actually, we can do it here because this looks like a normal AFI. So I can go to measure AFI, and then the image selection will start, or it will happen automatically. As you can see with AI, it has selected the apical long axis, and the region of interest was also selected automatically. And we can also overrule and select our region of interest as we see fit. The important thing is endocardium should be at the endocardium, epicardium should be at epicardium. The region of interest width can be increased or decreased depending on the global thickening. But if there's one area of scarring or thickening, I can change the thickness by changing the outer point of this region of interest. Once we process this, then you will see the 6 segments of the apical long axis. So you'll have basal, mid, and apical posterior, and then you have basal, mid, apical, anterolateral. The posterior, apparently the algorithm doesn't think it's tracking it well. I think we started too low in the base, so we can reprocess. We can bring this a little bit out and this one a little bit up, and I think it should be tracking it well now once we reprocess. Here again, it's tracking it much better, but it's giving a low velocity, low strain value, I think because of this. This is the early one, which is high. That's giving me a positive value. So I can, again, I can reprocess and make sure that it is within the field of view. Again, if you include pericardium, it will always give you false data. I'll actually overrule and accept this. And here the value is -10. It's okay, but again, this is in false information because of the base during early diastole, early systole. So again, we can approve and select next, and we can go to the 4-chamber. And again, the view recognition happened automatically. The region of interest happened automatically, was selected automatically, but still we can always overrule and try to make changes and try to select the proper ROI to go to the right endocardial border and process. And again, we can check the myocardium and we can check the thickness to make sure that it includes the epicardium, but it does not include the pericardium. You can see here, this is the longitudinal strain curve for all 6 segments. You can see the strain is timed perfectly for all the segments, and the peak strain is more or less the same, around 20. So we can go approve and select next to the 2-chamber. Then we will see the 2-chamber. Here's the ROI suggested. Here's the actual one drawn, and I don't think it is that curved. However, we can make sure that we include the real endocardium in different places. Anytime we can also adjust the gain, so we can actually double check and readjust the endocardium. And again, we can also change the epicardium or the outer epicardium to make sure that it includes the real epicardium and not the pericardium. Processing will start the segmentation and the strain tracing. And again, these are the curves for all the segments and the actual strain value. And here we have the, also, as I mentioned, we can do EF for the 2-chamber. We could have also done it for the 4-chamber. So we have the ejection fraction. If there's anything I disagree with, I can actually change manually and still get the values. Again, here we can go to the bullseye with traces or bullseye only. So you can see the traces of the 6 segments from 4-chamber. These are the segments from 2-chamber. These are the segments from 3-chamber or apical long axis. And here's the modified 17 segments. We said that there are different color maps, if you remember. So let's go to bullseye only and change the color maps. Here's the peak longitudinal strain for each segment. So we can go to peak systolic strain, the different color, as I mentioned, green normal, yellow borderline, red hypokinetic. Not much. This could be when you see a small, just one part of a segment like this, you know it's probably not traced well. So you can either readjust or just ignore as long as the rest looks normal. Then here you have the PSI, post-systolic index, and these are the segments that have a certain percentage of the strain happening post-systolic, 16%, 12%, 2%, 5%, nothing significant. And here, as I mentioned, the TTP, the time to peak strain, again, you can see the time to peak strain for most of these segments is around 350 to 400 milliseconds, not significant. Again, peak strain dispersion, 35 milliseconds. If it is above 120 milliseconds, that's an indication of asynchrony. Peak strain dispersion of 35 milliseconds is not significant. And the global strain value, of course, and all the parameters here. Then additionally, we can also go to myocardial work, enter the blood pressure, and hence we'll take the event timing into consideration, mitral valve closure, aortic valve opening closure, and so forth. Then we can go to the blood pressure, enter it, approve, and then we can see the actual myocardial work index, the actual work for each segment. And here the work efficiency, the percentage of work done during systole. And here either the peak strain or the time to peak strain can be presented here. We can do segmental assessment, so we can compare the actual strain pressure curve for the global as well as for each segment. For example, this is a bit off. And again, in the bottom here, it shows me also the global average and the segmental constructive versus wasted work. Constructive is in green, wasted work is in blue for each of these segments. So this is for myocardial work. If I'm happy with all these results, I can just approve and exit, or I can just go to the, yes, or I can just go to the four-chamber view with the RV, and I can do strain for the RV as well. So we can go to measure. We can go to AFI RV. And then despite it is a little bit missing the apex of the RV in this view, we should have a better image for the RV. Nevertheless, here's an RV free wall. This is only showing systole. Here's the RV septal insertion. Here's the RV apex. And again, you will see now the segmentation happening for the entire RV. This should be a little bit more out. This should be a little bit more in, I think. And we can widen the yo-yo at mid systole. And now I'll process and let me check the segmentation, how it's done. And now you can see the strain curve for each one of these segments. It looks as if it's tracking everything well. Even you can see the excursion properly. Here, it's not sure that it's tracking it well, but because most of it is out of the field of view, but whatever speckle is there can be averaged and or smooth, and maybe I can take that. Maybe I can accept that. Okay. So, or we can just reprocess and maybe bring this in a little bit and maybe bring the apex down a little bit. And process. Okay, still not taken, but I'll accept it. Then here are the strain curves for each segment. And you have the global strain for the RV, minus 25. The free wall strain, again, always higher, minus 29%. And the TAPSI, 2.7 centimeters displacement. So this is for the RV strain. We also have the 4-chamber and 2-chamber, so I'll show you how we can do the LA strain. I'm sorry. Let me also get this out of the way. Okay, so here we have the 4-chamber, we have the 2-chamber, and more or less we have the maximum left atrium from 4-chamber and from 2-chamber. And I'll just go to measure, and we will do AFI for left atrium. And again, we can start with the 4-chamber. Here's 1 point septal basal, lateral base, and LA roof, which is here. And of course, we try to avoid this pulmonary vein, but we want to include the entire LA process. As you can see, since we can see the pulmonary left upper pulmonary vein, we can see the right ones. It's not really an optimal view for the LA, but nevertheless, it's useful, and we have the values. We have the reservoir strain 40% positive, conduit strain -26, contraction strain -14. Maximum LA volume is 71 ml. So I can approve and select next, and then I can go to the 2-chamber image and then tell the machine this is my 2-chamber. And again, inferior base, anterior base, and LA roof here. And you will see the segmentation or the entire ROI tracing and process. And here also it will do longitudinal strain. It will treat this entire LA as if it is one segment, and it will give us entire calculation of conduit strain, reservoir strain, and contraction strain for the 2-chamber, which is here in the bottom, and even calculating the EF if we want to. So it can give me the EF, and even for the EF, I can do adjustments. And of course, as you know, with LA, we always try to exaggerate as much as possible. And here it's giving me the ejection fraction of the LA, which is 60%, which is a little bit exaggerated also because the diastolic one is a bit foreshortened. Yeah, so here's biplane, the strain values, and we can just approve or just simply cancel to exit. Any questions about LA strain or RV strain so far? And here, this is where we can also do an example of, if I may exit measurements. The frame rate is only 17 frames per second. We can do a 4D strain, but for 4D strain, we require at least 25 frames per second. Of course, this is the limitation of 4D. We cannot have much higher frames per second. So that's probably the only compromise in 4D is that the frame rate is much less than 2D, but nevertheless, we have a lot more speckle because in 4D, again, we have the entire segment. So we have the speckle inside the entire segment. It's not like only a cross section of the segment. So we have a lot more data to work with during these 25 frames per second for the entire strain of the LV. So how does it work? We go to measure. We go to volume. Actually, we start with for the LV quantification, same as we did in the last session. So we go to end-diastolic volume. We simply select 2 points, one in mid base, one in apex. And then we go to end systole, and likewise mid base and apex. And then we go to maybe adjust this endocardium, because we need to have the calculation done accurately also for the strain. So we go to volume waveform. I should have adjusted also the 4-chamber and the 3-chamber here. Nevertheless, we'll see what happens when we go to LV mass. And then we'll go to 4D strain ROI results. Let's just jump to it, the results, and see how it looks like. Strain values in 4D. Again, as explained before, we are working with the entire speckle of the entire segment. It's not a cut plane, it's not endocardial, it's not pericardial or myocardium, it's the whole thing. So it takes a little time to process, but it's a lot more data. It's much less sample rate, but it's a lot more pixel or voxel or speckled data than a normal 2D. So here we have the longitudinal strain. The segment was not accepted well, but nevertheless, we can actually manually accept it by going to segment. We can check the segments one by one. And here we can actually approve the segment manually. And here we have, most importantly, we have the longitudinal strain. I can go to nsystole, and we can go to longitudinal strain. Here's the global longitudinal strain value. Here are the segmental strain, and you can see the longitudinal strain during systole for all of the 18 segments, and during early diastole and atrial contraction. This is longitudinal, this is circumferential. It should have the same curves more or less, and this is the average of all 18 segments, and this is the global circumferential strain. Area strain, as I mentioned, it's more or less the summation of longitudinal and circumferential. Longitudinal was 21, circumferential was 20. Sum is minus 41. Here it's showing sum of minus 37 for the area strain, for the area of each segment. And then we have the radial strain, which is again going to be inverted. It's going to be a positive strain. And here's the global radial strain, positive 63% average of all these segments. And then we also have the rotation, and the rotation shows me the rotation of the basal ring, the rotation of the mid, and the rotation of the apical ring, and then the instantaneous rotation of each one of them, and then the twist, which is the difference between the basal and apical rotation at insystole in value, which is 3%. Then there's also torsion, and then there's also, again, segmental. We can check each segment. So basically, when we are doing longitudinal strain, then we can also get longitudinal displacement as well. Torsion, rotation. Okay, yeah, longitudinal strain. So here we can have it either dynamic or static. We can have the region of interest dynamic as well. Okay, so this is for 4D strain. Questions about 4D strain before we go further? Again, any questions or comments, please feel free to ask me or stop me anytime. Okay, so last but not the least, I will show you the study with the stress, which is R1.
So if I can ask about myocardial performance, what's the clinical use of this? How much is it useful, I mean, in the clinical practice, myocardial performance?
You mean myocardial work?
Yeah, myocardial work,
yeah.
Yes.
Yeah. Basically, myocardial work overcomes the pressure pressure load limitation of the strain, or changes of the strain resulting from pressure load. So if you have a patient that you do an AFI for, and the value is for the GLS is -14, let's say, okay, which is, or -12, let's say, which is close to borderline hypokinesia, and then you start after 2 months or 6 months or so, and then you do strain again, and then you find the value is actually reduced, it's -10. However, the blood pressure went up from -12, from 120 over 80 to maybe 180 over 100. So the strain, the reduction in the strain value is normal when you take the blood pressure into consideration. So because there is this
Sorry about that, but Jordat will rejoin. Jordat, can you hear us?
Hello, sorry, can you hear me now? Hello, can you hear me now?
Yes, yes, we can hear you.
Okay, thanks. Sorry, so as I was saying, myocardial work will overcome the pressure load challenge. So does that answer your question? Or did you?
Yeah. I thought there is more than this. Actually, I tried with patients with left bundle branch block induced cardiomyopathy. And then when you treat them with beta blockers and ICE or IRBs, you'll see improvement in the constructive work and decrement in the other, the
Wasted work.
the wasted work. So clinically, you will see the patient is improved, and you see the number of constructive work is improved also. And maybe this patient is candidate for CRTD or not, but with medical therapy, you will see better improvement in the constructive work. I saw it like this. I saw it in 1 or 2 patients, and these 2 patients didn't require the CRT at least. But I don't know how much it's beneficial in other cardiology. I mean, in other type of patients. I know in left bundle and blood pressure, especially in tumor patients who need chemotherapy, and then you will see the GLS is low because of blood pressure, not because of chemotherapy. This is very important, especially in chemotherapy patient. You see the number, the GLS is low, but you don't know whether this is from blood pressure or medication. So this might make difference. Thank you. That's great.
Thank you. That's on the contrary. I'm very happy to hear your comment about the LBB patients. This is very good input. To be honest, this is the first time I hear this, but it sounds like a great way of utilizing myocardial work. Absolutely.
You know, because using beta blocker will reduce the time. You know, the time with the wastage time. You know, the delay of septal contraction compared to the lateral wall
Yes.
contraction. So this time, which is causing this wastage of energy or wastage of the wastage of work. If you give beta blocker, the time will reduce and the performance will improve. The wastage work will reduce and constructive work will improve. So you will see this. You will see this objectively using myocardial work. I use it for for a couple of patients. It's useful actually.
That's great. Great. Thank you very much. Okay, so this is an example of AFI being used with the stress echo, and this is actually a protocol that we have within the Vivid systems, which is called AFI stress. So basically, you can see here, this
Sorry,
is a
Jordat,
four-stage.
you're not sharing
yes?
your screen. We can't see your screen.
I'm not. Okay, sorry, because
No.
I lost connection. I
No
lost my
worries,
screen
but we
also.
see
Okay.
you, but we don't
Okay,
see your
that's good.
screen.
That's good. That's good. Okay, so let me go back to sharing my screen. All right, so I hope it's being visible now, my screen.
Perfect. Thank you.
Thank you. That's too... Okay, so again, this is an example. As you can see, this is an actual protocol in the, if you go to the templates when you're doing a stress echo, this is a protocol called AFI stress. And there's also different protocols for exercise as well as pharmacological. You can also have the template editor that where you can add more views and more stages on the stress echo. So here in this protocol, you can see there are only 3 views, which are the 3 apical views, 4-chamber, 2-chamber, and apical long axis. And here you have 4 stages: baseline, low dose, peak, and recovery. And if you go to each one of the doses or each one of the stages, for example, baseline, you can go to analyze for that baseline stage, and you can go to measurements to do score. So you can see here AFI is done for the baseline. So for example, baseline AFI, select baseline AFI. When you are in the baseline stage, you do a baseline AFI. And you can see it was done already. So this is the AFI for the baseline for this patient. You can see the global GLS is minus 13.9. You can see different regions, mainly LAD a little bit reduced in the basal segments, and the right circumflex, right coronary as well. If you look at the low dose bullseye, this is the bullseye done for the low dose. Again, it looks improved in the left coronary, a little bit of reduction in the right side. But if you go to the peak for this patient, look at the circumflex now. You can see it's giving us different information here, the circumflex as well as the LAD territories. You can see huge reduction in the strain. The GLS, the global strain value it's not showing here for some reason, but we can actually go to the AFI again, and you can see the values, the actual values for this peak.
Is this a DBS or this is stress echo?
This is the vitamin. You can see here the times. I cannot tell from the notes. This is T1. yeah, I mean, you have the low dose and peak and recovery. So of course, it's the vitamin stress eco. It's not an exercise. But for somehow I'm not able to access the peak, the global average here. If I stop. And here you have different maps. You have the peak systolic strain. You have the peak dose and the PSI, post-systolic index. And here it shows you all the segments that have post-systolic shortening as well. And this is the bullseye only. Still, it is not showing the actual value. So I don't know, for some reason it's not showing the average, because in the other stages it was showing the global value. Here it is not showing the global value. But again, you can see the different bullseye from different stages, and you can even display them side by side. If we go to the protocol again, and you go here, then it should show you. I think it's not showing the part where I can have more selections because of the graphic card again, because my laptop is working with Zoom at the same time, so I'm not able to access the full functionality. But anyway, this is the general idea of AFI with stress.
So I don't know here, how can we depend on this? Can we compare the rest stage AFI with the peak? Especially we have different loading conditions. So you have, for example, patient blood pressure might be 200 at peak. You have low strain or low GLS during peak. So how can you compare rest with the peak with different blood pressure?
Yes, so the idea is not rest with peak in terms of values. The idea of detecting which areas are ischemic, which coronary zone is ischemic according to, because if you're doing wall scoring, you will also get the same results more or less. You're going to end up scoring these segments as hypokinetic or dyskinetic or akinetic, but you're going to do it segment by segment in terms of the wall scoring that you have to do it manual. Here, the only difference is that instead of having to do the wall scoring and the bullseye manually, you simply do the AFI and you get more, let's say, more strain informed, longitudinal contractility informed data rather than the subjective data, which can vary also from one user to another. Here, for example, this is an example of a poor acquisition. You can see the apex of the 3-chamber, the apical excursion here, which means that we are getting foreshortened in this 3-chamber. In the 4-chamber, it looks ideal, it looks perfect. This is proper assessment, but you can see the apex is not affected much, maybe exaggerated values maybe from this, but it is the basal segments that are affected mostly, especially the circumflex. For me, the surprise in this study between the baseline and the peak is the circumflex zone. Okay.
Yeah, thank you.
There's another study I would like to show you, which is, I think, this one. I think this is the last one. As I promised last time, we are trying to keep these sessions within 90 minutes. So this is a nice study for AFI. I think this is a pacemaker patient, and you can see here, this is, I don't know if it's during adjustments or post pre-post pacemaker, but you can see here the time to peak strain. Here it's 430, here it's 540. I don't see the, or is it here? The peak strain dispersion, 69 milliseconds. So you can see there's asynchrony here that is going on during the time of adjustment, while here these are the strain values, but you can let's do an AFI for the actual study, for the actual views. AFI. So here you can see the segmentation is done. The region of interest was already automatically selected. Maybe I'll exclude this part of the papillary as well, because this is still papillary 2. I'm okay with this. So here we have the strain, the longitudinal strain values. And you can see a little bit of difference in the time to peak strain, but anyway, we'll approve and select next. We can even do EF here from 4-chamber endocardial border in diastole and in systole. If you disagree with this, I can also increase this area. Likewise in 2-chamber. If you want your measurement to be a little bit more accurate. Still EF 53% and diastolic volume 140.
Jordat,
Yes.
we have a G security and maintenance update BIOS asking to restart now, postpone in 5 on the screen.
How much time do we have?
No, it's a little window that's come up on top of your window.
Oh, really? Is
Yeah.
it from my
From
laptop?
It's from mine. I'm so sorry.
Okay. All right, no problem. Okay, so here's the 4-chamber. So we can go to approve and select next. Then we can go to the 2-chamber, and AI recognize this is a 2-chamber, and it will it has drawn the region of interest. And again, we can adjust to make sure that we have the endocardium. From 2-chamber, and then process. And again, the peak systolic strain for each value, you can check the quality of the speckle tracking. You can check also the waveforms. Happy with that, approve and select next. Then we can go again. We can also do EF for this 2-chamber. So for example, here we make adjustments for the volume in diastole and systole. And we have the EF, the 2-chamber in diastolic volume and systolic volume. Then we can just approve and select next. Then we can go to the 3-chamber, and here's the image. And again, view recognition automatic for the 3-chamber view process. And here are the strain values. You can check here. This is probably one of the main things, is to check the base, because many times the strong speckle from the annulus can give me a bit of a jump during early systole. So just try to avoid that. Then you can get a normal value for the base. Otherwise, it can be an overestimated or underestimated strain value. Or of course, if your point is too low within the atrium, then you will have an inverted strain effect from the atrium. Then it's going to be really underestimated strain values for the basal segments. So once you are finished, then you can go to the bullseye, and here's the bullseye for the strain values. However, if you change this, you can go to the green yellow, which is, here it looks, everything looks perfect, but here, if you go to the green yellow, you can see these basal segments a bit on the border of hypokinesia, Then you can go to the other one, which is PSI, which is post-systolic index, and shows you these segments have a post-systolic shortening. In other words, there's some strain that is happening post-systole. If you look at the bases, then these same segments that you are getting a post-systolic value, for example, this here that has a high PSI, it's the green one, as you can see, the green waveform here, which is showing lots of strain that is happening post-systole. Likewise, this segment that's also showing some strain happening post-systole. Likewise, this segment in which is the which color is this? This is the red one, which is showing also some strain happening post-systole. So again, these are the segments that are showing some strain or some curvature that is happening post-systole. Then we can go to next one, which is the time to peak strain, and that's showing me the time to peak strain and the peak strain dispersion, the standard deviation of the difference in milliseconds between all the segments, 72, 73 milliseconds. So here you have 387, here you have 545. The difference here is actually almost 170 plus milliseconds, you know, 13 plus 45, it's almost 160, let's say, milliseconds between this segment and this segment. Likewise, between this one here, 387 or 422 to 545, that's also a difference of 130 milliseconds. This is why there's a bit of a difference in color between these different segments. And this is the peak strain dispersion. It's not a typical asynchrony, but I think it's because this patient is actually an asynchrony patient with a pacemaker. As you can see here from this 4-chamber, there is a pacemaker. In the, would you like to know? You can see here there is an actual pacemaker. Yeah. So you can see the catheter, there is a pacemaker. So this is a cardiovergent patient, maybe if you, or adjustments are happening. Okay, questions or comments? Okay, if there are no more questions or comments, I'm happy to close the session. I hope it was a bit useful on the how to, again, to implement these different tools in practice, and how to acquire and quantify these different tools. Again, if your camera is on, please do turn it off or
So, Mr. Jawdat, the Achilles heel of all these measurement is the quality of image. So if you don't have good quality, good image quality, the measurement, you cannot trust the measurement. You know, all the measurement we are doing with this. This is the problem with the speckle tracking.
Absolutely. I mean, absolutely. Just like everything else in echo and in medical imaging in general, you know, if it's not a good quality image, then it's nothing good can come of it. No good diagnosis can come out of it.
Yeah, the other problem, if we are using little contrast, maybe it's not allowed. I mean, to do any GLS with small amount of contrast. I mean, it's not allowed, right? I mean, to do anything with the contrast.
Not that I know of, because contrast will only give you opacification of the endocardium, but it might, unless if you mean perfusion contrast of the myocardium itself, then it's too much speckle and too much information. I don't know if AFI works with contrast, to be honest, in the first place.
It's not working. I tried. I don't know the mechanism, but it's not working. It's not give you it will not give you anything. So
Yes.
if you allow me a question outside the subject within
Please.
the stress echo, as you talk about stress echo, there is I mean in the GE machines, all GE machines having coronary flow reserve, coronary flow reserve, which is actually a very nice tool to assess to Doppler the coronary, especially the LAD. If you are doing the stress echo and you have the LAD, if you can Doppler the LAD, the flow at rest and at the trace and at the peak, you might get a lot of information, And there is a tool called CRF on all GE machines, and there is preset in all the machines. But I mean, we don't have teaching on that. We are underutilized this. Maybe in certain part of the world, they are using this, which is maybe with the competency of 70% in stress echo cases. So do you have any comment on that?
To be honest, no, but I mean, in general, in all stress echo protocols, during the protocol, you can always freeze the protocol and then go do scanning, color Doppler, coronary. We have the quick apps on the coronary. So even if your image is focused on the stress, on the 2D image of the stress, and you try to switch on color Doppler, you want to see the coronary, you don't have to lose the geometry. You can just go to the quick apps, and then it will show you color that is optimized for coronary flow. And then you can Doppler it as you mentioned. You can apply PW and change the sample volume to match the diameter of the coronary artery, and get the Doppler waveform of it, whether it's systole, diastole, or as you mentioned with the reserve, measuring the Doppler in before stress and during different stages. So yes, thank you for mentioning that, and you can apply it in the routine. I mean, within the study. So you can freeze the study so that any acquisition, any images that will not intervene with the flow of the stress protocol studies. So it will not be considered as another 4-chamber or another 2-chamber view, because you're trying to acquire the specific views for the different stages. You can pause it, and then you can go and acquire, store, whatever, and then you can resume the stress protocol.
Yeah, thank you. I mean, we didn't see teaching sessions on that from G, especially on G website, or I mean, I didn't see like this. That's my question. We don't know the
Yes.
preset is okay on all the machine, or they need some adjustment. We don't know the filter, the color setting, the other things. So,
like I said, the color setting and the preset is actually called coronary flow. And it is in the quick apps of the you don't have to change the preset. It is in the quick apps, which is like a symbol of an icon symbol of a thunder, if I may say, or an electric current or a thunder, let's say. You can select that, and you can have the coronary preset or sub preset, let's say, without losing the geometry, without losing the depth or the width of the image that you have selected, or the zooming, which was already specific to a certain view. If teaching wise, we'll be happy to get the ideas. Maybe we can have this discussion offline. If you can send me an email or your contact. Maybe you can be also, we can have you welcome you as a host on the next session to speak about it as well. We would love that, actually, to share your experience also, and as well with it.
Thank you very much. I'm just learning actually from you. Thank you.
Believe me, I learned a lot more from you than you have from me during these last 2-3 sessions. Really, Dr. Walid, I appreciate your input so much.
Thank you, sir.
Okay, so are there any other questions or comments?
Jodat, can you see the chat?
Yes. Yes, I can see there is a chat. Okay, seems like E95 do not have the option for LA and RV strain. Actually, Vivid E95 does have the option, but it's only the latest E95, which has been released in September of last year, which is called a Vivid E95 version 204. So any E95 that is 204 and above should have the options for LA and RV strain. They are called AFI RV and AFI LA. And again, these are typically optional features. So chances are, if the local purchasing agent did not request it, maybe you don't have it, even if you have the latest. But most likely, if you have the latest R4, then it is either there or easily can be added to the configuration. Thanks for pointing that out. What is the place of strain test for DCM follow-up and treatment response? What is the place of strain test for DCM? Can you please elaborate on that, Dr. Demike? And treatment response. I'm sorry, I don't get the abbreviation. What is DCM?
Dilated cardiomyopathy. Sorry.
Yes. Hi. Strain test for dilated cardiomyopathy, follow-up and treatment response. Yes, I mean, you get the global longitudinal strain. So if it's a global cardiomyopathy or dilated cardiomyopathy, then yes, the global strain will change, and you can follow it up with the patient responding to either therapy or I don't know what other things, I mean, that are being done for global hypokinesia. Also, if it is micro vascular treatments, statin treatments, I don't know what else is being used in terms of therapy for such patients, to be honest. Again, I have to always point out the first, the obvious, which is I'm not a cardiologist, I'm a biomedical engineer by trade. So, but if you can also elaborate, I mean, is this what you expect from strain, is to follow up with the patient response in therapy and different treatment methods?
Yes, sure. You raised it perfectly, because in practice we usually use ejection fraction and other parameters to see that whether the patient has improved with the treatment or not. But technically, yes, it's not easy to identify the change with treatment, because they usually have a global poor or hypokinesia. It's global form. So by taking a sample ejection fraction, it doesn't technically, or fractional shortening, it doesn't actually help us in following patients. It can be used for the first time that to diagnose and to help you start treatment. But during follow-up, I think it's the strain testing can help. That's the feeling I have, because I don't usually use the strain test, and I was just to see how it potentially helps in following patients after we have had a diagnosis and starting treatment.
Yes, absolutely, I agree. I mean, that's the whole idea of, because you have a quantitative value for the global longitudinal strain, and you have the bullseye also to compare. So whether it's global hypokinesia or ischemia or regional level, you still have a good, because especially, for example, for regional, because overall ejection fraction might not change much if there's improvement or deterioration, but at least the strain value, the regional, the segmental strain, and as well as the global, and the bullseye, which represents again the coronary perfusion or perfused areas within the myocardium, and their strain values will be a good way to follow up for such patients. So.
Okay, thank you. In the meantime, do you have the standardized Z value for the strain test? I didn't find. Where can I find it?
In the Vivid Club, we have all the literatures and white papers with the actual values as per the EACVI protocols. So the values are there in the white papers and the clinical papers. And I think if you have the there's also an application for the ESC that also indicates all the normal values, and GLS is one of them. I remember one of your colleagues showing me this. It's a phone app that has the standard values even for things like diameters, ejection fraction, strain, and all others. For the adults, for the pediatrics, for the males, females, and so forth.
Okay, I didn't see it on PageZ. That's what I use is the PageZ. It's an app. It's a phone app, and I'll check it specifically for strain test. Thank you so much.
PageZ. Okay, it's good. I can try to look into it myself. But also, if you go to the Vivid Club, you will find lots of material about AFI and about the standard values for different age groups. And yeah, thanks.
All right. Okay. Thank you so much.
Okay, I think our time is finished. We only have 1 more minute to wrap up. If there are any other questions or comments, I'm more than happy to answer it. Otherwise, we'll give it a few seconds. Let's see. Any questions or comments? Great, thank you very much. Really, I appreciate all the input and all the engagement from everyone and all your patience throughout these sessions. This was the 4th session. We have only 1 more. Next week, we will talk a little bit more about 4D and the tools that are used for structural heart interventions. And again, thank you very much. This has been really great. I'm very happy to have these sessions with you, and looking forward for further sessions in the near future. Thanks again, and good night, and have a pleasant evening. Thanks.
Thank you very much.
Thank you, Sophie. Really appreciate all your efforts organizing this also.
Thank you. Have a good evening, everyone.